Hey, can you guys hear me okay?
Yep.
Yep.
Okay, awesome. Sorry, I was having some issues with Zoom. It wouldn't let me call in. All right, so I'm going to do a quick talk. I'm going to try and maybe return back to my rundown style where it's not that long of a lecture, because really hypercalcemia, this is something that does seem to come up. And honestly, I picked it because I'm not good at managing it, because it's something I feel like I had to keep looking up and stuff like that. So it was kind of out of selfishness because I figured I'd be able to get some learning out of it too. So I wanted to just review it real quick for you guys. So we're going to go over kind of how to evaluate it. I'm not going to go through all the different differentials. I'm just going to go through some of the major ones I think you're going to need to know, not just for your boards, but really in clinical practice. What I do want you to get out of it is what's a good flowchart way of managing it in terms of what labs you order and what order you order them in and how that affects what your differential is, and then the treatments and how they differ. Those are the two things out of this entire talk I want you to get out of it. And then, we're not going to really go into the counseling of the patients, the options, but it's going to go into that's a little more advanced, but I will touch on it, but I'm not really feeling like you need to be able to understand that. So it's really, most of the time it's made incidentally on your patients that aren't symptomatic. The old tried and true kind of thing that you learned probably in medical school and that I think still kind of holds back now is when you notice it or you diagnose it on the outpatient setting, then it's probably primary hyperparathyroidism, but when you find it in the hospital, it's more likely malignant. And the reason why is because the patients that are asymptomatic, that's usually going to be the primary hyperparathyroidism. And once they're symptomatic enough that it's causing, nephrolithiasis, your stones, Brown, psychiatric overtones type picture, that's probably because it's malignant. Your primary hyperparathyroidism will let your calcium get up to a certain level, but it's not going to be really that high. And I'll go through the mild, moderate, and severe levels. So that's the reason where that came from. These symptoms really going to come in to your moderate to severe levels. But remember, the most common times you're going to see these, most commonly, not always, most commonly is going to be your ones that are secondary to malignancies. And those are the two primary types, malignancy and primary hyperparathyroidism. On your boards, would they or may they get into secondary and tertiary? Maybe, but most of the time they only have so many questions they can ask you that the questions are going to try and be behind not just differentiating between these two, but then knowing what's the management plan that you want to do for that patient. Just remember, when it comes to the primary, secondary, and tertiary, when someone has tertiary hyperparathyroidism, it's usually because they have end-stage renal disease, so there's some phosphorus issue. The initial diagnostic workup will include the intact parathyroid, so not your parathyroid-related peptide, but the actual PTH itself. That's going to be the first branch point, and I do have a flow chart that I think does a good job of explaining that, because when it's low, that's suggestive that you can have a malignancy association. So there's some other, maybe that PTHRP is causing it to be low, or it's stimulating then the release of calcium, which leads to parathyroid itself not being needed. So then it drops in levels in your serum. But there are rare instances where you can have, and I didn't know this, I learned about it when I was making this for you guys, was that some malignancies, and I don't know which ones specifically, and I'll go over the ones that are more common for hypercalcemia, but some can produce stimulation of calcium directly through parathyroid. So then you might not actually see any change in the PTH. It might stay normal, which is why when you're trying to learn or memorize what's up and what's down in terms of, okay, calcium's up, vitamins down, that means it has to be this condition. That's why sometimes you'll see it say normal or elevated, because some malignancies can actually cause that to be stimulated directly. Most of the patients you're going to will have benign course, especially if you're diagnosing this on the outpatient side. It's those ones that you get concerned about that keep us up at night, that have a malignancy source that maybe we miss or that we're working up. And those are the ones clearly that we're going to admit because their calcium is so high that we know that there's probably going to be some cardiac manifestations from that. Of all these bullets, even though everything I'm really kind of mentioning is important, from a treatment perspective, hydration is always going to be the answer. All right. The times that you're going to be thinking about doing diuresis is if you have someone who unfortunately has a combination of heart failure and hypercalcemia. In those patients, you're clearly going to be concerned about, well, if I really aggressively hydrate them, I might push them into cardiac overload. So in those ones, you might do a combination of both because you're really trying to pull that water out, but you're trying to filter the water through the kidney, because by filtering it through the kidney, you're hopefully getting some of that calcium out of the body. So it's kind of the same idea, when you have your DKA patients, you're trying to get that glucose in them on top of, insulin management. the first thing is not just giving them insulin or putting on insulin drug. The first treatment is always to give them that fluid, not sugar, give them the fluid to try and dilute it. Why do we care about calcium? We really don't, but I guess we should. You know, it's essential for muscle contraction, nerve signaling. We know that going back to, so do you give direct? And I would. It's one of those rare times where you give both of them together. I would give both of them together to try and help with that fluid resuscitation, to dilute, but at the same time, not give them too much fluid that you're going to be causing them to go into like a flash pulmonary edema or cardiac overload. Good question. But remember that calcium is highly contained in your cardiac muscle, which is why, you know, arrhythmias are something that we have to be very cognizant about. I just put these numbers in here. Don't really worry about it. But the idea is that we might take a lot. You might see these patients are on like 5 different multivitamins. They take more multivitamins than they actually take a prescribed medication. It's like, what are you doing? And I just tell them, you just have expensive urine is really what it comes down to. But most of the calcium they're actually not going to be able to even absorb. So the real mechanisms, and this is important, it might seem like, why are we going this basic? I personally, that's how I have to learn things. I have to really go back to the basic physiology, like open up Harrison's, try and understand that so you can understand the pathophysiology of something. If you know the 3 areas that we're going to be able to get calcium from, then the mechanism of the parathyroid hormone itself will start to make sense. So we can get calcium reabsorption from the intestines, from the kidneys, and from the skeletal bones themselves, which is really where a lot of the treatment is going to be centered around of how to prevent it from getting worse. And then the kidneys are going to work together with the skin, you know, from a vitamin D standpoint to affect even the intestinal absorption. So what are those players when we're talking about calcium? Because it's clearly not just calcium. The major player is parathyroid itself, because its job is to recruit calcium from any of these potential background sources I just talked about, the intestines, the kidneys, and the skeletal system. So when the calcium levels will drop, PTH is going to tell the bones, hey, I need you to get some calcium from you. So they're going to take that calcium from the bone, and it's going to release the calcium into that circulation. Again, I might be going into basics, and I try to insult your intelligence, but I'm very comfortable with saying that I needed to understand at this level for it to make sense. When that happens with the PTH being instructed to do this, it also will prompt reabsorption in other areas, because you can't just take it from the bones. So you need it from the kidneys, pretty much at the distal tubules. And then the reabsorption is going to also happen in the intestines, under the intestines, the skeletal system, and the kidneys. Because what's going to happen is the kidneys are going to take 25 OH, which is made from the skin, and it's going to convert it to 125 OH at the proximal tubule, and that's going to allow reabsorption at the intestines to actually occur. So there's clearly a direct correlation between skin and then the kidney system and then the intestines. So it is important to know that. Okay, so when calcium decreases, as I mentioned, PTH is going to increase, and then vice versa. And then when calcium is high, the PTH is going to drop appropriately, as well as the 125, because you don't really need that absorption to happen. So you should see a drop in 125 as well, which is what the boards and stuff like that will try and ask you about. They're not going to say, oh, someone's hyperparathyroid, what's the calcium going to be, or what's the PTH going to be? You know that. They're going to ask you what's happening to that vitamin D, because that's that byproduct, but they want you to understand the connection between the two. This is important. I think it comes up maybe more commonly on hypocalcemia, but I think it's still important to mention now that 40% of our calcium is bound to albumin. So there's a total calcium level, there's a free, and then like the ionized or so. And the changes to the albumin directly will affect it, which is why we always correct it, right, for the albumin levels. I didn't put the formula in here because you'll need to memorize it. So why fill up a slide? You can look it up. You're not expected to memorize that on your boards. But you should know that only this ionized level is actually metabolically active. And if you're going to even order an ionized level, it needs to be fresh and it needs to be run immediately. If you order on the floor, it's probably not going to be done ideally the best way you'd like it to. Not anything against the phlebotomist, it's just they have a lot of patients to see. But in the ICU, you might be more likely to be able to get it run accurately if a nurse is able to run it down for you. So going over the hormones, we have the parathyroid hormone, which is going to increase calcium, obviously. And then as a result, if you remember one mnemonic I remember for PTH was phosphorus trashing hormone, PTH. So then the phosphorus levels are going to go down. The effect it's going to have, it's going to break down that bone to allow for reabsorption of your calcium into your, or to take in, reabsorb or bring calcium into the bloodstream, because clearly there's not enough, which is why it got stimulated. The indirect effects, it's going to affect calcitriol and 1-hydroxylation. We don't need to get into that, but that's what I was talking about with the 25 and 125 OH. And then if we go into calcitriol, vitamin D, again, that directly can lead to increased calcium levels. That's why when our patients were, trying to correct their calcium or vitamin D before we put them on bisphosphonates. Those are kind of going to go hand in hand. But calcitriol is going to have an opposite effect on phosphorus. It's actually going to increase phosphorus levels in the blood, but it's not going to have any effect on osteoblasts or anything in the bone directly. It's going to allow calcium to obviously just go up for the bones to eventually take them in. But again, no direct effects anywhere else. It's going to allow us to absorb in the intestines, though, just not the kidneys. And then calcitonin will cause calcium levels to go down. Why does that matter? Because calcitonin is going to be one of the primary medications that we can use to help patients with hypercalcemia. It's also going to decrease your phosphorus levels in the blood. And by decreasing calcium, the way it's going to decrease calcium levels, it's going to inhibit the breakdown of the calcium from the bone. So when the bone is getting eaten away to kind of produce all this calcium, the calcitonin is going to prevent that. So then it's going to, from a balancing perspective, it's going to lead to more of a promotion of calcium into the bones itself, leading to a lower level of serum. All right, so clinical symptoms. So this is what I was getting at. Mild, it's going to be about less than 12. I don't think you really need to memorize these levels, to be honest with you. I think the two you should really know is 12 or 14. If it's 12 or less, it's going to be asymptomatic. That's probably going to be your primary hyperparathyroidism. If it's moderate, then patients are probably going to show some fatigue, maybe some constipation, very non-specific symptoms, which is why when I was a resident, our commander for our clinic or for our residency, she was a colonel, she was an endocrinologist, and no matter what differential diagnosis, and this is probably going to happen next week now, whatever the differential diagnosis, she always had calcium abnormalities in it. So she always wanted a calcium level on patients because they can really present any of these ways. And then severe, greater than 14, this is where you're thinking it's going to be a malignant cause, and this is when your arrhythmias are going to start coming in, cardiac arrest, stupor, coma, even pancreatitis, patients coming with abdominal pain. It's probably either related to constipation, as mentioned above, or true-on pancreatitis. I put some charts in here to show you. Oh, can we please start calling Dr. Timmerman Commander? Do it. She'll look at you confused, and then she'll probably eventually start liking it because it's kind of fun to be called a commander. So I put some charts to kind of show the same information different ways. So remember 12 and 14 are those big numbers to know about. So mild is going to be in your 12 level. So look at the calcium level here. This is the ionized level. And then hypercalcemic crisis, probably going to happen at 14 above with your malignant sources. Same information, just a different way of looking at it. And then if we were to look at the information by system instead, we could say in general, you'd see some weakness, dehydration, you might see some depression or mental status changes, GI, the pancreatitis, even some abdominal pain and constipation. Renal, they're going to look like your diabetes patients. Nephrolithiasis is going to be a very important thing to know about because patients that present with hypercalcemia and nephrolithiasis are more likely to require surgical intervention, not just pharmacologic intervention. Fearless leader, comrade. Oh, Russian Max. But you're not, Max, you're not Russian, right? Is it Ukrainian? I'll wait for the response. I thought that's maybe not. Close enough, fair enough. All right, and then hypertension and arrhythmias I should have put there. And then we could look at the clinical manifestations. Again, a different chart just showing the same information. I'm not just going to go into it, but just know about the bone pain, the stones, bones, abdominal moans, psychiatric overtones, all that stuff that we kind of learned about. And then with the cardiac arrhythmias, things you might want to monitor on our patients in the hospital on the floors. You're going to put them on telemetry and start looking for some of these changes over time that might be leading you into thinking that this person's probably going to need some interventions sooner than later. So the initial evaluation, when you see someone, it's get a total calcium level because you might, with a free and an ionized, you're going to get a serum creatinine because you're looking for some kidney dysfunction that can happen with these patients. And then obviously you're going to get that parathyroid. If the parathyroid is elevated, so you're going to get these first, all right? Don't just get a shotgun workup. You get these levels first. If the parathyroid hormone is elevated, you're going to then look to order a 24-hour urine calcium and a creatinine level. I'm going to get to the flow chart why, because that's going to help you decipher if this is familial hypercalciuric hypercalcemia or if this is true-on primary hyperparathyroidism, secondary, tertiary. This next level, the urine, is what's going to be the primary way of you determining that. You could get x-rays to look for, nephrolithiasis, vertebral compression fractures. That would be only well after you've gotten to this point because these are going to help you from a management perspective, not a diagnosis, but when you're deciding how aggressive you want to be, if you think a parathyroidectomy is necessary, then you can do that. Yep, you can do a spot calcium, absolutely, Max. So just like we don't do 24-hour albumin levels or protein creatinine levels, you could, you can do a spot level as well. And then you can get a BMD or bone mineral density as well. just to make sure that there's evidence of osteoporosis, because if someone has osteoporosis, then clearly you're going to be a little more aggressive. And if they have vitamin D deficiency, then go ahead and replete it. This is a cool chart that I saw on Up to Date, but I also found one that I think they used it from, that kind of shows how the serum levels of your total calcium affect the actual and the PTH itself. So if you have a PTH that's going to be very high on both ends, so the PTH is high, the calcium level is high, then it's probably going to be primary hyperparathyroidism, not necessarily very severe, because we said that severe hypercalcemia is probably likely to be your malignant, whereas the mild is going to be your primary hyperparathyroidism. But when the serum concentrations are really high and the PTH is low, you're thinking of that malignancy. So you can see what the red is showing is that the PTH was really suppressed, right? Because the calcium level was so high, so it's more malignant. But when the PTH really was not suppressed much, and then the calcium wasn't really affected as well, it's more in the 12 range, that's more likely going to be primary hyperparathyroidism. But it's not completely clear cut, right? You can have those outliers where some patients are not going to follow the textbook. Another way of looking at this is on the next chart. So the primary hyperparathyroidism patients, again, are going to have this total calcium level in the mild range, like in the 12 for the most part, with an intact parathyroid hormone that's going to be pretty preserved. But then when you have your malignancy, they're going to have a total calcium level that's probably going to range more in the 14s. You could still see some overlap right in the 12s, but the PTH is going to be severely depressed. So that's why that's the first level or lab you want to get an idea of what your differential is going to really include. So when you make the diagnosis, clearly patients that have a primary hyperparathyroidism, it's directly the parathyroidism that's causing hypercalcemia, so both should be up. But some patients could theoretically have a normal PTH with a normal calcium. It's just not common, and you're not going to be tested on that because it doesn't fit the perfect picture, which is what boards like to test you on. Differentiating between secondary and primary is challenging. They're not going to really ask you about it. I put this fractional excretion of calcium because you can use that if you really wanted to know more in depth. It's really over the intent of this rundown talk. But if you wanted to know, like, well, if I wanted to decipher between primary and secondary, how would I do that? You get a fractional excretion of calcium. And in patients with primary hyperparathyroidism, they should not have a low urine calcium in clearance. So it should be greater than 1%, just like our phenas. So if they have a greater than 1%, then it's going to be a primary hyperparathyroidism. If they have less than 1%, it's more likely, not completely, but it's more likely to be secondary or tertiary. And especially if they have end-stage renal disease, it's almost always going to be tertiary. And that's because of the duration of how long they've had usually that phosphorus abnormality that has led to kidney dysfunction. Differentials, we talked about this, 60% of cases are really going to be primary hyperparathyroidism, whereas the 40% that remain are going to be more malignant associated. When you think of what malignancies should we be worried about, you're going to be thinking about ones that can affect bone themselves. Maybe it's going to lead to more of a bone breakdown, which then releases the calcium as a byproduct, and even your perineoplastic conditions, because they're going to create that PTHRP. So think Hodgkin's lymphoma. Hodgkin's lymphoma usually has a bimodal distribution, which I brought up in previous lectures, young and really old. And it's also going to cause that vitamin D to be up. So that's why the vitamin D is something they'd like to test you on the board, because if you see that correlation, maybe the person has neck pain or a neck that's not supple, then you would say, oh, maybe this is Hodgkin's lymphoma or unattended weight loss, the B symptoms. You know, squamous cell carcinoma, we know that from our lung cancers because that's the one they really like to test you on for PTHRP. Solid tumor, yeah, it's the same thing for solid tumors of the lung. You can get this with skin squamous as well, by the way. Esophageal cancers, you know, if you have someone that has Barrett's or so, cervix or cervical cancers, breast, and even kidney. And then remember your granulomatous or inflammatory causes. There's going to be infectious and non-infectious, which is how they're usually divided. And they're also going to lead to an increased vitamin D because of the organism or the granulomatous process itself is going to produce vitamin D. So if you think of infectious, you're worried about PCP or, you know, pneumocystis jirovecii is like the new term. I say new, but I think it's still been out there for like 6 years. But just like Wegener's and all, they'll say, oh, the new term is this. It's going to take probably decades for them truly to change. TB, histoplasmosis, and then your non-infectious, like I mentioned, the Wegener's, sarcoid, and even your inflammatory bowel disease. I think the inflammatory bowel disease is probably going to be hard to find your hypercalcemia early on unless you're really on it and you order it, because there's symptoms of abdominal pain, constipation, even though they're more likely to have diarrhea. I think you're probably more likely to attribute it to just, oh, that's just their IBD. It's not really an electrolyte abnormality. So my guess would be that these patients probably have a delay in diagnosis just because of the non-specificity of their symptoms. And then obviously drugs that in themselves could lead to elevated calcium or thiazides, and less likely your lithium just because we're not seeing as many patients on it unless they have drug-resistant depression. So if something's PTH, you can divide them another way of either it's related to PTH or it's not related to PTH. If it's related to PTH, it's either PTH itself, which is clearly going to cause these associations, and then it's going to drop your phosphorus and your vitamin D levels, or it could be familial hypocalciuric hypercalcemia. And remember, actually, I'm going to test you guys. What was the thing that you want to get after your PTH is elevated to help decipher between the two? So put it in the chat box. What was the next lab I told you to get? You can get the fractional excretion, yeah, the 24-hour urine or the spot. So it's the spot urine calcium. The fractional excretion was to decipher between primary and secondary, ideally, of hyperparathyroidism, but it's really that urine calcium, yeah. And then if it's familial hypocalciuric, you can just tell just based on the name that the urine calcium should be low. I guess the answer was really there. So I give none of you credit because the answer was actually in the box. And then non-PTH mediated, it's going to be your malignancy. So you're going to have PTH dropped because the condition itself, the cancer, is going to produce that PTHRP, which is going to stimulate PTH and then drop, which because it's seeing this elevated calcium, which is stimulated by the cancer product itself. But vitamin D can be thrown off because it can be elevated in lymphomas, even your granulomatous conditions. Recall that. I think I have the flow chart next. Yeah. So this is of all the flow charts I saw, this was the best one, and this is from the American Academy of Family Physicians. It's a lot. What I want you to get out of it is just skip all the way down to here. So measure that PTH. Once you've confirmed that it's high, you're going to get that urinary level of spot urine protein, or calcium, like Max had mentioned. I added GFR and serum creatinine because it's going to help you early on decipher very quickly what your management plan is. If you see that that level is low, then this is going to be that familial cause. And then you can typically see a calcium creatinine clearance of less than 0.01 because it's clearly low. If it's normal or high, then you're thinking your primary or tertiary, even secondary causes. You can get your fractional excretion of calcium at this point if you want to decipher between it. And then this is where you're going to see, my mouse keeps disappearing on this. I don't know if I can, pointer, pen. Okay, there we go. So at this point, you're going to try to decide what's the management plan, and that's why you're going to order either a sesame scan to kind of look at, and I have an image of that later, because it's going to help localize where is this tumor on the parathyroid gland to help that surgeon, because what the problem is with these surgeries is there is a high risk for complications, whether it's loss of your not vocal cords, but if they hit the laryngeal nerve, you're going to get a hoarse voice for the rest of your life. If they accidentally take out too much of the parathyroid, or they start hitting into your thyroid glands themselves, there could be issues. So they always want to get the scan to be able to decipher where it is from a localization standpoint, and then they'll do that parathyroidectomy. Other reasons why you do that is if you do these labs and you see that this person has any problems with their kidney function or the nephrolithiasis, as I mentioned earlier. But if you get this PTH level and it's actually low, now you're thinking about maybe there's a cancer going on, there's some tumor. So you're going to order that PTHRP. You could start looking for lung cancers. Maybe you're going to get a chest x-ray. If you got an alk phos already because it was part of your CMP and it's elevated, that's when we typically see us order like this GGT to kind of localize it to the bone or the GI system. And again, I also put, this is when you can consider ordering the bone scan, because if you order it, like we did here, that's going to be another reason that maybe you're going to be a little more aggressive and try and take them out, unless you're going to just treat the cause of the suppression, which is going to be the cancer itself. Most of the time when I was in residency and as undergrad, I did really bad teaching on whiteboards, because you can imagine by the time I was done, my whiteboards kind of just looked like this. So this is no different. So I'll leave you guys with that work. So very quickly, primary hyperparathyroidism. Oh, here we go. I may have missed you saying this in the beginning, but when your patient has an elevated calcium for the first time, how long do you usually wait before rechecking and confirm it's truly high before starting a workup? I don't think there's a need to wait unless you think that you've identified the cause. Like, I just started them on hydrochlorothiazide. I think that this is why their calcium's up. I'm just going to wait for them to maybe normalize, or maybe I'm going to decrease the dose. But if you don't have a cause, and especially if they have symptoms, I wouldn't technically wait 4 to 6 or 12 weeks. I would probably put them on, like, recheck it now, because it really shouldn't change unless you can identify the cause. So I would say at most a week, I would personally wait. I wouldn't wait 4 weeks unless they don't have any symptoms, and you think this is, since this is an outpatient setting probably, so you think this is primary hyperparathyroidism, which if they don't have those symptoms from it, you're probably not going to be super aggressive with it to begin with. So background, we already talked about this. Your side effects, the kidney stones, these side effects are the things that are going to lead to you, oh, there you go, wanting to kind of do some interventions or treatments, whether it's parathyroidectomy or getting them on medications. And then if you have someone that's less than 40 years old, you should be looking for genetic causes for this on top of asking the family history. Medical treatment, IV hydration, okay? Normal saline, 0.9%. You're going to give them a lot, 2 to 4 liters. That's why I said if they have concurrent heart failure, you're going to give them the diuretics at the same time. That's really the only time that this furosemide is going to come into place. It's going to help the kidneys kind of filter and eventually remove that calcium. If the patient doesn't have heart failure, other times you could use this Lasix if it's a really severe level. So if what level did I tell you to remember that if it's above this number, it's severe? And it's not in the slide, so I'll give you credit for it. 14, yeah, good job. So if it's 14 or above, that's where it's severe. So that's when you could consider using Lasix. IV zoledronic acid, which is a bisphosphonate, is a really great medication to use. You're going to use 4 milligrams over 15 minutes. It's going to target those osteoclasts to prevent them from breaking down the bone and releasing more calcium into the bloodstream. It does take time, though. It takes 24 to 48 hours. So you don't just put this patient on that medication and then wait and hope you've actually treated them. So one time I did this as a resident. I haven't really seen that many hypercalcemias here that I recall. It was a young guy. It was a Navy seaman, and he had testicular cancer. So we were thinking that this was secondary to that. So we ended up putting him on IV zoledronic acid, but then also put him on calcitonin because that's going to give you that more immediate effect. When do you not use Lasix? What creatinine level? Oh, that's a great question. Or do you base it on urine output? That is a great question. I would say that if you have a high enough creatinine level where they're oliguric too, and they're like producing no urine, you're probably going to be starting going towards dialysis. Like you might want to get nephrology involved and say, hey, I really want to put them on Lasix or get these interventions in, but I don't think that's going to do anything. I think they're going to go into fluid overload, and I'm probably going to get a flash pulmonary edema. So I can't give you an exact creatinine level. It's going to be based off what your comfort is. But if you see someone had their baseline of like 0.9, and maybe now they have like a creatinine of 3, and they literally have no GFR because of how suddenly it went up, I don't think Lasix is going to be doing anything to them. I think that at that point you need to consider dialysis. You generally don't use it ever only in heart failure. Yeah, so Lasix, absolutely. So if they have severe, that's when you can use Lasix. What I'm saying is when they have mild hypercalcemia, like that 12 or less, you're not really using Lasix for those patients. Again, and so put that zoledronic acid, it's going to take some time. So as a result, your calcitonin is going to be your main medication because that's going to act very fast. You have IM sub-Q, even the intranasal route, but IM and sub-Q is the one that we kind of use for the most part because usually with hypercalcemia, they have concurrent renal failure. They can, dependent on how bad it is, right? So your milds don't necessarily have renal failure, but if they're not oliguric and they're still providing some urine output and you don't see other abnormalities that would suggest overt renal failure, like the phosphorus is severely elevated, the potassium severely elevated, maybe their sodium is really low, I wouldn't say that you have to jump straight to dialysis. So it's really going to be based on how comfortable you are. And if the patient doesn't have, obstruction or like, hey, doc, I haven't been peeing all day, like, maybe I'm going to try some hydration. Maybe we'll do gentle hydration, see how they respond. And if they get some good urine output from that, then you can continue, like start at 2, and then you can jump up to like 4. But if they're not responding, and maybe you get a chest X-ray after, and you're like, okay, this person's retaining all this fluid because their kidneys are not functioning, that tells you right there the Lasix is not going to do anything. You need to get them into dialysis. Replace the vitamin D if you can. And then there are some people that will recommend hydrocortisone IV daily. I only saw it in 2 sources. Just know that. That might be a question you could ask endo specifically. But calcitonin, of this slide that I made beautiful now, I want you to do IV hydration, zoledronic acid, and calcitonin. Those are the 3 things I want you to always remember. Surgery is curative about 95%, and you're going to do it when you see all these side effects, which is why I told you to get that imaging later on, because it's going to help from that management perspective. But what are the complications? That laryngeal paralysis, and I mean that's lifelong, right? You can't fix that. And then even hypoparathyroidism, because they take out not just the section where the adenoma might exist, but they take out the entire parathyroid in an accident, that could happen. I do remember as a resident or a medical student, I sat in on at parathyroidectomy, and at that point I already knew I didn't want to be a surgeon, and I remember I fell asleep, I think somehow standing up, which was pretty cool. I did not fall on the patient though, I was still sterile. Benefits, reducing the incidence of nephrolithiasis. So these patients have recurrent kidney stones. That's the benefit of surgery. And if they have osteoporosis, after about 10 years, you can see some improvement with it. This is that image I was telling you about. So you can see the thyroid here, but this is that nodule, that adenoma that they're seeing in that inferior thyroid gland. So you can use this sesame scan to kind of help you from a surgical perspective and help the surgeons out localize that gland before they actually have to do surgery. And we're thinking of cancers. I've talked about this in the Hodgkin's and Hodgkin's lymphoma, your T cell, your breast and lung cancers, those things that inhibit or act on osteoclasts to promote their function. Remember that vitamin D, less than 1% of these cases are even going to be related to the vitamin D, but you can see some elevations in your granulomatous condition. Just know that the tumors are really going to be squamous. This is what they like to test you on, just making sure you know that. And it's going to cause that direct osteolysis, leading to that bone, as I went back before, the loss in the bone mineral density results of that. So these patients are typically going to have some osteoporosis as well. You know the breast cancers and lung cancers, what they like to test you on is lung cancer and knowing that association with squamous cell carcinoma. But drooling while sleeping. I don't think I was drooling at that point, but I think later on I was definitely exposed to animals that had rabies over in Afghanistan. So maybe at some point, if you guys see me drooling on rounds, stand away, get away from me and see if I have a fear of water. Management, denosumab. So we know this as Prolia for osteoporosis, and it's called Xgeva. I don't know how to pronounce that. For cancer, it's the same medication, though. It takes about 70 to 48 hours or 24 or so to reach the effect. Remember that. So that's why you have to get that calcitonin short term. I'm not going to get into the vitamin D issues because it's really not necessary. But because I want to really stick this to not more than half an hour, and I'm right at half an hour. So let's go to a quick summary. The serum concentrations are going to be assessed with that ionized level because that's the actual active level, not your total. But you can do it if you have only a total and then use your albumin to correct for it to try and get like a quick way. Most common causes are going to be your primary hyperparathyroidism and your malignancy. And remember that 12 and 14, 12 is mild, greater than 14 is your moderate, and that's going to affect kind of what your differential is going to be, whether it's PHP versus malignancy. The most commonly associated with some kind of bone reabsorption, right? The calcium just isn't going to appear out of nowhere. You're going to see some absorption from the intestines, the kidneys, and the bone. And all those avenues are what we're going to utilize to try and manage the treatment of it by decreasing the calcium. Evaluation of that allergy is going to start with a PTH, remember. So get that PTH first. Once you find out if it's elevated, then you're going to get the urine levels. And if the urine levels are elevated, you confirm, oh, not that one, you're going to confirm PHP there. But if it's low, then you're going to do the familial. If the PTH is low, then you know that this is potentially a secondary source that's causing stimulation of calcium. So you're going to look for your cancers, your granulomatous diseases, et cetera, like histo and coccidiomycosis. Acute treatment is always going to be IV hydration regardless of the cause. All right, it doesn't matter if it's malignancy or not. Just treat them with saline. You can use Lasix if it's moderate. You can also use it if you think that there's concurrent kidney issues or risk for heart failure. And then use bisphosphonates, even though it's going to take about 40 to 72 hours to go in. So I knew this question was going to come up. Dharmesh asked about why not LR. All the studies have showed NS. I think there's calcium in LR. Yeah, Dylan just said it. So that's why we don't use LR. Normal saline doesn't have any of that. So that's why we're trying to use the normal saline. So LR, the time that they're going to test you on knowing when to use LR for the most part, is with your pancreatitis patients. You always use LR. You're not going to use normal saline in pancreatitis. And here are my references. Of all the references, honestly, the best one was this AAFP article. It was in 2003, but that's why I used some of the newer articles to just make sure that the information was the same and it didn't change. I didn't thank you, Dylan. I think she was thanking me. All right, I don't want to. Okay, what questions do you guys have? Oh, yeah, it was a female Carol, by the way. No questions? All right, hopefully that was helpful. That's my idea of rundowns. I used to give them last year, just a quick topic that I think comes up a lot, or just out of pure selfishness because it's something that I want to know that you guys could probably benefit from having a review too. So, oh, actually, I was recording it this time. I don't think there was audio, though. We'll see. I'll still